person, Dr. Garvit Chitkara. So I would like
Can you see my screen?
Yes.
Yes, ma'am.
Yeah. Okay, so I'm going to talk about malignant breast lesions. It's a very wide topic. So obviously I'm just going to talk about some of the there are some themes on all these slides. So we'll talk about all these cases. So we'll just talk about a few things. Obviously, I'm not covering the sarcomas and all. I'm just covering the epithelial lesions of the breast, malignant epithelial lesions. But before we start with the case discussion, I'm going to just spend 5 minutes on how to approach breast neural core biopsy. As you all know, the breast lesions could be symptomatic lesions or radiologically detected lesions. I think in there, probably you see more of the symptomatic lesions, while here we see quite a few mammographically detected lesions because of our national screening program. So the symptomatic lesions are the ones where the patient presents with a mass lesion. And so usually these are mass lesions. And if they're mass lesions, more likely to be invasive. It's only less than 1, maybe up to 5%, it could be just DCIS. While the radiologically detected lesions, which we see in the screening program, they could be either mass lesions or it could be, and they're usually impalpable, or they could be suspicious calcifications. So what are the types of mammographic abnormalities you see in the breast? The common one, is the mass lesion, which could be either rounded or it could be stellate, or it could be solid or cystic. There could be just asymmetric density, radial lesion, and microcalcification. And this is how our radiologists will describe any lesion which they see on mammography when they send us the biopsies. And they always try to categorize the radiological lesion. So obviously, if there's no abnormality identified, then it is R1. R2 is benign. And when it's R2, they very rarely take a biopsy. R3 is, they are not sure, but more likely to be benign. R4 would be suspicious, and R5 is cancer. So these are the categories they use, and they always provide this information when they send us the biopsy. So when we get a biopsy, we need to do the histology, radiology correlation. So how do we do that? And for doing that, we obviously need a good information from the person who is doing the biopsy. It could be done by the surgeon or it could be done by the radiologist. Over here, most of them are done by the radiologist. So we need to know what type of that. And for doing that, we obviously need a good information from the person who is doing the biopsy. It could be done by the surgeon or it could be done by the radiologist. Over here, most of them are done by the radiologist. So we need to know what type of lesion have they seen and they're biopsied. So whether it was a mass lesion or whether it was asymmetric density or calcifications. If it was a mass lesion, they have to tell us whether it was a rounded mass or whether it was a stellate mass, and whether it was cystic or solid. They always provide us with the R category, whether R3, R4, R5, size of the lesion, and what type of biopsy they have done, whether it is ultrasound guided biopsy or stereotactic biopsy, or sometimes now we get vacuum assisted biopsy. So this information is very, very important. So you encourage your surgeons or radiologists to give all this information. Okay, so when you get the core biopsy, how do you approach it? So first look up the clinical information. What is the lesion which has been biopsied? And then check whether you are looking at the correct slide. Screen the slide under low power first. Don't straight away go to high power, because you will miss a lot of things if you straight away go to high power, and you may make a wrong diagnosis. Once it is on the low power, when it's on the low power, see whether you got the targeted lesion in the core biopsy. So if it has been done for the mass lesion, look for the interface. So here is suppose this is the breast and that's a mass lesion here. Radiologist or whoever takes the biopsy usually tries to take the interface. So you do get the lesion and then the surrounding breast tissue. And you can see that interface, you can see very well over here. So you are kind of convinced now here that yes, we have got a mass lesion in the biopsy. And then the next step is obviously you have to interpret it. And once you interpret it, whether it is called it benign or malignant, the most important next step is that does your interpretation correlate with the radiological or clinical findings? So when you are approaching a core biopsy, three important steps are, first step is look up the clinical information, see what was the R category and what is the type of the lesion which has been biopsied. The second step, have you got the targeted lesion in the biopsy? And the third step, which is the very important step, is does your interpretation correlate with the radiological or clinical findings? So these are the three most important steps for core biopsy approach. So as I said, radiology pathology correlation is essential. And we in the UK, and I think even in Australia, they provide a diagnostic B category, which is quite helpful because our surgeons sometimes only look at the B category at the end of the report. So this is the B category. B1 means there is no abnormality identified. It may be totally benign. Say it has been done for a R3 rounded mass, question mark fibroadenoma, but I'm seeing just normal breast tissue. I'm not seeing interface. I'm not seeing a mass lesion. Then I would call it B1 because it's quite likely that the lesion has been missed. So once it is B1, they know that they have to repeat the biopsy. B2 is benign. So if it was R2 or R3, and if I say it's benign, then the patient is discharged. Unless the patient wants the lesion out, say fibroadenoma, needs to be, then they will excise it. B3 is that I'm not 100% sure what it is, but you know there are certain entities which fall under B3 category. One of them is ADH, the other one is classical LCI. So some of these lesions, they need to be excised because we need to examine more of the lesion. So that's why we give it a B3 category. B4 is suspicious. That means I have some tissue which I'm highly suspicious that it is either say high-grade DCIs or invasive cancer, but I don't have enough tissue in the core biopsy to give us a definite diagnosis. So when I report suspicious, they will always repeat the biopsy and try to give me a little more tissue so that next time I can give a definite diagnosis. And it is important because if I give a definite diagnosis, they can go ahead with the therapeutic excision rather than diagnostic excision. So this is very important that they repeat the biopsy. So the patient can be told before the surgery that this is what you have got, whether you got DCIs or whether you got invasive cancer. And B5 is cancer. So B5A, we use it for in situ carcinoma. B5B is invasive cancer. And sometimes we use B5C category where I am not certain that there is definite invasive cancer. There is DCIs, but whether there is invasive cancer or not, I'm not happy with it. Then I would call it B5C. It happens quite often with the papillary type lesions when we are not 100% sure whether there is invasion or not. Then we would call it B5C. So these are the diagnostic categories. And then how do we correlate these categories? So the triple assessment is the most important thing. Correlate with clinical findings, correlate with radiologic findings, with pathology findings. So say if it was R5 lesion radiologically, and I have got B5, either DCIs or invasive cancer, then it is a concordant finding. I mean, there is no discordance here, and they will go ahead, surgeon will go ahead with treatment. Therapeutics are the treatment, so either it will be lumpectomy or mastectomy, depending upon the scenario. If it is R2 or R3, and it is B2, say it is a R3 mass lesion, I've got a fibroadenoma, I'm going to call it B2. So it's concordant and you discharge. If it is B3, then as I said, that this excision is usually diagnostic excision. It's not therapeutic excision. So they would remove a very small amount of tissue. But nowadays, what they do is the vacuum-assisted excision or vacuum-assisted biopsy, where they can give us more tissue to examine. So for LCIs, classical LCIs or ADH, they will try to give me more tissue to see whether I can upgrade it or not. Okay? So that's for R3, B3 category. What about R5B2? That means radiologically, it's a very suspicious or it's almost malignant lesion, but I'm giving a B2 diagnosis. So it is discordant. But before giving that B2 diagnosis, I will have to make sure what am I dealing with. So for example, I've got fibromatosis. You all know that fibromatosis is a stellate lesion, and radiologically it looks like a malignant lesion. The other tumor which looks like that is granular cell tumor. Radiologically, it can look malignant, but it is benign. So actually, this will not be B2 category, but it would be B3 because they always excise the fibromatosis and granular cell tumor, not for giving me more tissue to make the diagnosis certain, but more likely that because these lesions are always excised. So R5B2 discordant, but we have explanation for that discordance. But R5B2, I would never put B2. I would always put it as B1 or B2 because this is a discordancy. More likely that the lesion has been missed and they have to repeat the biopsy. So, and there are three keys to guide the treatment, and that is communication, communication, and communication. And we have to communicate with our team. And that team includes, in the past, we were only communicating with the surgeon because we were only interacting with the surgeon in the past. Then gradually we started interacting with the breast radiologist as well. And now with the oncologist as well, because there is a lot of biomarkers which they would like to know. We gave a lot of neoadjuvant chemotherapy. We need oncologist input. So this communication is the most important part for proper management of the patient. And I think that's my introduction is over. If any questions, otherwise we can move on to cases. Any questions or any comments, anybody?
Nothing in chat, ma'am.
Nothing. So shall we move on to the cases then?
Yes, ma'am.
Okay, so case 1 was a 69 years old female. Okay, the clinical information, read it properly. Radiologically indeterminate R3 nodule. That means we have a well circumscribed lesion. It's most likely it's probably not a cystic nodule, but this was a solid nodule. And R3 means it could be benign or it could be malignant. So who's going to describe it now for me? Do you want to pick someone, please? Chairperson can speak. Poonam, somebody? Anybody?
I think Dr. Shikha, would you like to take it?
Okay. So, ma'am, this is an H&E stain section showing pores, breast parenchymal pores, showing extensive DCIS component with solid architecture at the low power.
Okay. Before we go on to the slightly high power, what was the radiological information given?
It's an R3 lesion.
It is a R3 and it was a well circumscribed nodule. Nodule means it's a well circumscribed. So do we have a well circumscribed lesion here or not?
Yeah, we are having.
We have. Can you see the interface here? See the interface here? That's the normal breast tissue here, and that's the lesion. And then here we have interface again. That's the normal breast tissue here, and we have interface, right? So we do have targeted lesion in the biopsy, right?
Yes, ma'am.
Now the next step is the interpretation. So how are we interpreting this? So do you want to, expand on your description? So far, so good.
Yeah. We are seeing the nest of the neoplastic cells having monomorphic appearance with a solid architecture mainly. At places, cribriforming is seen. And at places, cribriforming is seen. And these are well-defined nodules.
Yeah.
With the size of the nuclei is more than 2.5 times that of the lymphocyte. So these are the high-grade nuclei.
Yeah. So you think this is DCIS or invasive carcinoma? Did you look at the architecture under low power? Let's go back to low power over here.
Yeah.
Yeah. Oh, sorry. Yeah. So do you think that if it was DCIS, then the whole whole thing is a mass forming DCIS, or there are multiple foci of DCIS, right? So if there are multiple foci of DCIS, the normal breast architecture would still be retained, but all the ducts would be expanded by DCIS, right?
Yes, ma'am.
So here, what do you think within the lesion here? Do you think that the normal architecture is there?
No.
So which are the mass forming DCI lesions which form DCI's lesions which form a mass lesion? We'll come back to that later because we have a case like that. So the architecture seems to have gone, isn't it? There is no normal breast architecture, lobular architecture of the breast. So if it was DCIS, I would see there are like it's within the lobules. You'll see the ducts which are expanded by DCIS, right? But
Yes,
that
ma'am.
architecture we are not seeing, right? So there is something, it's not just right for DCIs, yeah? Yes.
Yes, an invasive component was also seen.
Okay.
These Kibri-forming arrangement of the tumor cells, infiltrating
right.
nest.
Yes. So there are infiltrating nests. Very good. That's the correct description. So there are infiltrating nests. So it cannot be DCIs, right? If it is invading the stroma. What do you describe more about this infiltrating nests? Are you seeing something at the periphery?
We are having the myoepithelial cells at the periphery of these.
Yeah, but how do you, have you seen a skin basal cell carcinoma? What do you see at the periphery over
It's
here?
like adenoid.
Palisading.
Palisading.
So we have got palisade. So we have got multiple nests of various sizes and shapes. There is palisading of nuclei. And you rightly described that their nuclei are not low grade. They are at least intermediate to high grade nuclei. There is some cribri forming, as you said, but most of the nests are solid. Yeah, most of the nests look solid here. And then at the periphery, if you look, when you have like always look at the entire slide properly, if you cannot come to a conclusion, you will probably have a diagnostic area somewhere else. So look at the entire lesion properly. Now here we are not seeing much of the cribri forming, much of tubule formation because they are all solidness here. But somewhere here, if you go here now, you are starting to see like tubules. And I think that's the highest power. You're starting to see tubules and some cribri forming and all. And also, are you seeing something within these tubules or tubular structures?
Yes, eosinophilic material.
Well done, very good. So now you have an infiltrating lesion. You have got some tubular structures, you've got some cribriform structures. Some of these cribriform structures have hyaline-like material within the lumina. So what, even if you can't come to does it remind you of any particular lesion anywhere else in the body? Any other
adenoid cystic carcinoma.
Well done. So what is your next steps? Are you going to give it straight away B5B like in adenoid cystic carcinoma? And you are going to grade it, obviously. You are going to use the Nottingham grading system.
Yes. According to the Nottingham grading system, the tubule formation is in 2, score 2.
2 to 3, maybe, yeah.
2 to 3.
Yeah.
Process is 1, mitotic activity is 1.
Yeah.
And nuclear pleomorphism is
2, at least.
2.
Yeah.
Then 2 to
so
1.
It comes to around 6, 7, right? So it is grade 2. So it was Nottingham grade 2. Okay, so now it is you're thinking of adenoid cystic carcinoma. It is not low grade adenoid cystic, it's not grade 1, but it is at least grade 2. Maybe you're not seeing a lot of mitotic figures in these areas, but there were mitotic figures. So it is slightly higher grade of adenoid cystic carcinoma. If it is, are you going to give that diagnosis or you are going to do anything more after this?
We will be doing an ISC.
Okay, what ISC?
CD117.
Yeah.
CD117.
What is your differential diagnosis here?
It can be a carcinoma
Yes,
or
invasive
adenomycystic
cribriform
carcinoma.
carcinoma. Yes, good. Okay, so before you request any stain, you need to know the sensitivity and specificity. So you need to know the pitfalls. So CD117, suppose I tell you that yes, there is patchy positivity. Will it help you?
No.
No, why? It's a very leading question, isn't it? Yeah, it won't help you because a lot of invasive breast carcinomas, even no specific types, can show you patchy CD117 positive. So you want to see really good diffuse CD117 positivity. But to differentiate adenocystic from invasive cribriform carcinoma, does
P63 we
that
can use.
interpretation, say I want to call this invasive cribriform carcinoma, will that fit with the radiological finding
No.
of a well circumscribed nodule?
No.
No, because most invasive cribriform carcinomas, they would be more infiltrating type. They will infiltrate the surrounding breast tissue. So it's not going to form a nice nodule, right?
P63 instead.
So one is, yes, interpretation for invasive cribriform carcinoma is not fitting very well with the radiological findings. What is the next step? You said CD117, okay.
P63.
Anything else?
P63.
Yes.
And PR HER2 status because it will be triple negative.
That's good. That's good. So, yeah. So any invasive cancer, you are going to anyway request ER/PR and HER2. So ER/PR and HER2 were negative, right? And
Yes.
then you wanted CD117. It's diffusely positive. So it is adenocystic carcinoma. Yeah. And it's
Yes,
grade 2. Yeah. So well done. Good description.
Thank you.
Okay, so this is a case 1 diagnosis, adenocystic carcinoma. We'll talk about this entity a little later. It was a solid or basaloid variant, and it is triple negative. So differential diagnosis to consider. Of course, this is not looking very high grade, but main thing, because it's a triple negative cancer, you have to differentiate it from triple negative basal-like carcinoma, which is a very, very aggressive neoplasm. But these is because they are very aggressive, they are very pleomorphic. You will get this type of necrosis, but these can form well circumscribed mass lesion. Okay, so triple negative basal-like carcinomas can be well circumscribed. So that's not against the radiological findings, okay? But it would be very high grade, and there would be necrosis and all. And triple negativity is not going to help you. But say if it was a very high grade adenocystic, that triple negativity is not going to help you. And then you are going to turn to CD117. If that doesn't help you, then you may have to go to molecular test, okay? And so that's our basaloid adenocystic and that triple negative basal-like carcinoma. Okay, so it's very pleomorphic and there is necrosis there. Large cell neuroendocrine carcinomas, they can have nest formation, they can have peripheral palisading, but again, you would expect much more nuclear pleomorphism, much more mitotic activity in geographical areas of necrosis. We will talk about the neuroendocrine tumors of the breast a little later, which is a very controversial topic. So we'll talk about, but it's not that because it's not as pleomorphic as that. But if you have in doubt, you can do neuroendocrine markers. And this was the excision biopsy of this case 1, and we are getting nice. What is this, the pink material? Do you know? What is it supposed to be?
Basal.
What is it made up of? What exactly it is supposed to be?
Basement
Basement membrane material.
Good. Yeah. So it can be. So that was the final diagnosis, solid basaloid variant. And that's what I wanted to talk about, that basement membrane-like material. It can look eosinophilic, or it can sometimes look even bluish. It may have a bluish tinge. So this was a nice classical variant of adenocystic, which we'll talk about. So let's talk about adenocystic breast carcinomas. They are rare. They are less than 1% of breast carcinomas. Mean age is around 60, 65. Quite often they are subareolar in location. And as I said, they are generally generally well circumscribed mass lesions. And just like in salivary gland adenocystic carcinomas, they are composed of two cell types, epithelial and myoepithelial. And the WHO subtypes, we have three variants. Classical variant, which can have cribriform morphology, tubular or trabecular, and you can have mixed patterns in one particular tumor. Solid or basiloid variant, which was our example. And sometimes you get high-grade transformation, which is very rare. Immunoprofile, you rightly mentioned everything. Myoepithelial, because there are myoepithelial cells, you will have myoepithelial cell markers positivity. You will have epithelial cell marker positivity. They are positive for CD117, but be careful when you are using CD117. Patchy positivity does not confirm adenocystic carcinoma. They are typically triple negative. They are basal-like. So they are like, immunoprofile is very similar to triple negative high-grade basal-like carcinoma. But you really want to differentiate the two because the management is completely different. And these tumors, just like salivary gland carcinomas, they are characterized by MIB and FIB fusion. So if you are really stuck, you may want to do this. And sometimes there is no fusion, but there is rearrangement of MIB L1, L2. You can also do MIB overexpression, ISC, or in situ hybridization. So what is the prognosis of adenocystic carcinoma? If it's a classical variant, it's excellent, right? If it's basaloid variant, it is likely more aggressive than the classical variant. It, of course, is also dependent on the Nottingham grade, but your basaloid variant will turn out to be either grade 2 or grade 3. So it's not going to be grade 1. So grade 1, the classical ones are usually grade 1. Rate of lymph node metastasis is very low unless it's a basaloid variant or there is high-grade transformation. So what is the management of adenocystic? We need complete surgical excision. Role of sentinel node biopsy is kind of, yes, it definitely we need it in basaloid variant. But in classical variant, it's debatable whether to do sentinel lymph node biopsy or not. And usually after lumpectomy, not after mastectomy, after lumpectomy, usually they are given radiotherapy. Obviously, you don't give hormonal therapy because they are ERPR negative. They don't need chemotherapy unless there is metastasis in the lymph node, which is more common with the basaloid variant. So suppose there is a basaloid variant and there is lymph node metastasis. What is the role of neoadjuvant chemotherapy? Because most triple negative high-grade basal-like cancers will end up with neoadjuvant chemotherapy if they are not very early stage. We don't know the response. Probably they don't respond to neoadjuvant chemotherapy, but we don't have enough data on that. So they are very similar to salivary gland tumors. Histology is similar, immunoprofile is similar, and molecular changes are similar. But the prognosis is pretty different, very different, in fact. If it's a classical variant or even low-grade basaloid variant, there is very rarely you get lymph node metastasis, very rarely you get perineural invasion, and 10-year survival rate is more than 90% as opposed to salivary gland adenocystic carcinomas. So this is a very typical classical variant of adenocystic carcinoma, cribriform. So when you get this and when you get basement membrane-like material, there is no problem. But sometimes you do end up with problems as usual. So here is, I'm going to show you a case. It was a R3, well-circumscribed mass, which was increasing in size, and a core biopsy was performed. So we got this core biopsy here. We have a nice interface here. That's the normal breast tissue. And then here is the mass lesion, right? And this is what it looked like. A lot of this highly nice tissue, some duct-like structure, some compressed ducts and all, right? And this was the pathologist's diagnosis at the time, collagenous spherulosis, right? So let's go with 3 steps, which I told you. Look at the clinical information, right? The clinical information was well-defined mass lesion. And why was pathologist calling it collagenous spherulosis? So suppose you look at this particular area on that core biopsy, Looks very similar to collagenous ferrulosis, right? This is a collagenous ferrulosis, and this is our case. They look very similar. So I can understand why it was called collagenous ferrulosis. But what is the problem here? So we go through our 3 steps. It was done for a mass lesion, right? We found a mass lesion in the core biopsy. And the interpretation of the pathologist was collagenous ferrulosis. Does that match with the radiologist finding of a mass lesion, right? What do you think? Yes or no? Anybody? Anyone would like to answer that? Does the interpretation match the radiological findings? Interpretation of collagenous ferrulosis. The diagnosis collagenous ferrulosis, does it match radiologist interpretation? The radiologist finding rather.
No.
Yes or no?
No.
No. Why?
It will be a benign lesion, pathologically, collagenous ferrulosis.
Yeah, but it was R3, so R3 could still be benign. Because R3 is almost quite often is actually benign because they are not sure, but they biopsy. So R3, R4, when they say it is suspicious, R3 most likely benign. So why does it not correlate with the radiological findings? What exactly is collagenous ferrulosis? Have you come across that anytime? Okay, I'll tell you. So radiological abnormality was mass lesion. Collagenous ferrulosis is not a mass forming lesion. It is typically an incidental microscopic finding. It doesn't form a mass lesion, right? You will just see a tiny focus of collagenous ferrulosis in somewhere else. Something else is going on in the breast, but you will see that. So it is an incidental finding. It does not form a mass lesion. So your interpretation if it is collagen, it does not match with the radiological interpretation of a mass lesion, right? And it's not just radiological interpretation. We do have a mass lesion in the biopsy, right? We do have a mass lesion in the biopsy. So suppose if it was collagenous ferrulosis, it would have been just tiny focus over here. Rest of it would have been something else, normal breast tissue or something else. Okay, so it does not match. So how do you, suppose you are still doubting, which shouldn't be because collagenous ferrulosis does not form a mass lesion. You can do CD117 and it was diffusely positive. It's negative in collagenous ferrulosis. But remember, collagenous ferrulosis does not present as a mass lesion. And this was excised and it was adenocystic carcinoma. Just one other feature about collagenous ferrulosis is that when the lobule is involved by LCIS, it mimics DCIS because of this lumen formation. This is all basement membrane-like material. Again, in collagenous ferrulosis, it's the same type of material, but it mimics DCIS, though this is classical LCIS. So this one pitfall you have to remember when you are looking at collagen. And it's not uncommonly, I wouldn't say quite often, but not uncommonly, LCIS is involved by collagenous ferrulosis as well. So don't make a diagnosis of DCIS because it's forming nice lumina, okay? So these cells are actually, if you see, they are discohesive cells. So these are LCIS cells mimicking. And if you're in doubt, we'll talk about LCIS a little later. So that's, I think, case 1 is finished. Any questions on case 1? Or should we move on to case 2 now? Anything? Any questions on the chat?
No questions, ma'am. Someone just commented as some amyloidosis, I think, about the collagenous ferrulosis.
That's good. Yeah. Amyloidosis, yes, it can. Usually, again, it can, so I suppose, present as a mass lesion, but it usually presents as calcifications. But yeah, if you are in doubt, you do amyloid stain. But amyloidosis will not have those ductal epithelial cells, which we saw in the amyloid should not have these cells, right? And you will always see around the amyloid either some plasma cells or giant cells or something like that. But and again, it will not be like this type of architecture, like literally round structures, amyloid. But if in doubt, yeah, you can do amyloid. But I would not expect to see all these ductal structures, which are very monomorphic. They are not even, that's not normal breast tissue even, because there are no this is not normal breast tissue, right? But if in doubt, yeah, you can do amyloid stain. Okay, any other questions?
No, ma'am.
Okay, so we'll go to case 2, which is we have 58 years old female, radiologically indeterminate, R3. It was a well circumscribed solid nodule. Okay, who's volunteering here?
May I?
Yeah, sure, go ahead.
Ma'am, the H&E sections of low power field 4x6 specimen showing some microcystic and tubular structures along with proliferation of epithelial cells. Ma'am, I need high power view. Within these microcystic structures, there are eosinophilic secretions.
Yeah.
And the neoplastic cells having round to oval monomorphic nuclei and have eosinophilic and some having accumulated cytoplasm.
Yeah, good description. So let's just go back to the low power. So it was a mass lesion, which you are convinced there is a mass lesion, right? So there is a sharp demarcation there. Yeah. So we have this whole thing is a solid mass here. So first 2 steps we are now happy with. And now comes to the interpretation. And you have described it quite well. We have some microcystic spaces, some tubular structures. We have got these eosinophilic secretions. There are some vacuolator cells. So what's your diagnosis?
Ma'am, it may be a case of secretory carcinoma.
Well done, well done. So we have a theme here, isn't it? So it is a secretory carcinoma. So how will you confirm it, or you will just sign it out as secretory carcinoma? And does it fit with the radiological findings? Do secretory carcinomas present as well circumscribed mass lesion? And do they present in this age group?
Yes, ma'am. Its age group is bimodal age. It can present in children, also in adult and older age.
That's true. Yes. So yes.
And further investigations like specialist brain and IHC for confirmation.
Yeah. So clinically, it fits with the clinical picture. As you said, bimodal age presentation. It fits with the radiological finding with a well circumscribed nodule because they are usually well circumscribed. And now the interpretation, what you are saying is secretory carcinoma. Would you like to confirm with something, or you are happy? You said you would like to do some immunos. What immunos would you do?
We can go like S100, CEA.
Yeah.
And also ERPR.
Yeah. So what do you expect with all this? You have to tell me your findings as well. What do you expect? So what will you expect with S100?
Yes, secretory carcinoma is supposed to be triple negative.
Yes.
Also, the S100 will be positive and CEA will be positive.
Yeah. Okay, that's good. I don't have any immunos because we really didn't do any immunos because this is a very typical picture of a secretory carcinoma here. But as you said, yes, there is S100 positive, CK5 positive. And if you are always, then you can do molecular tests, but there's really no need. So let's talk about secretory carcinoma. So this was secretory carcinoma. Very rare, mean age 53, but you can get in children. Generally, they are well circumscribed lesions. And you describe correctly microcystic, solid, small nests, vacuolated cells with intra and extracellular secretory material. And usually they are grade 1 or 2. Very rarely they are high grade. And they are characterized just like salivary gland secretory carcinomas. They have ETV6 and TRAC3 fusion, so you can do that molecular test, and that's a very specific test for secretory carcinoma in the breast. Immunoprofile you already described is 100 CK5, and all these stains are positive. ERPR, HER2. Sometimes you can get patchy, very focal ERPR positivity, but overall they are ERPR, HER2 negative. They can be positive for PanTrack, IHC, right?
Yes.
And very indolent tumors, especially in children and young adults. They can be aggressive in older patients. and they respond to TRK inhibitors if there are advanced secretory, if somebody has advanced secretory carcinoma. Okay. So that's any questions about secretory carcinoma? It looks just very similar to salivary gland secretory carcinoma and indolent behavior, triple negative. Any questions?
No questions, ma'am.
Okay. So yeah, the theme of the first two slides was salivary gland-like breast carcinomas. So what are the other salivary gland-like breast carcinomas? Are mucoepidermoid and polymorphous. They are very rare. I've seen mucoepidermoid. I have not seen polymorphous adenocarcinoma. Maybe I have not diagnosed any polymorphous adenocarcinoma in the breast. But these two are supposed to be quite rare. And again, this is very similar to the salivary gland mucoepidermal carcinoma. So they will have mammal2 positivity. Ethnic cell carcinoma actually is now is not considered to be a salivary gland-like breast carcinoma because it is genetically very similar to microglandular adenosis. In fact, they arise sometimes from microglandular adenosis. So it's supposed to be now different from the salivary gland counterpart. So these are the 4 typical salivary gland-like breast carcinomas. They are typically triple negative, usually indolent clinical behavior, and genetic alterations are very similar to salivary gland counterparts. So this was the theme for the first 2 slides, salivary gland-like carcinomas. Remember, they are triple negative, but often they are low grade. Okay, so next one. Case 3. 60 years old, radiologically suspicious distortion. Now we have R4 distortion, not a mass lesion. And this was excised. I don't have a core biopsy to show you, but I have the excision. Who is describing this? Any volunteers? Anybody?
I think, can Dr. Vaishnavi take this?
Vaishnavi? Yeah? I can't hear.
Dr. Richa, would you like to describe?
Yes, ma'am. Ma'am, section from breast tissue shows, ma'am, cystic spaces,
Yeah.
which are filled with squamous pearls.
Okay, before we describe the high power theme, what about the low power, lowest power? We have said it was R4 distortion. Do we have distortion here or not? You know what distortion looks like. It's almost like stellate lesion, like radiating type lesion. Do we have that here?
Yes, ma'am.
So we have a radiating type lesion. You can see it is kind of going in all different directions, right? So yes, we have a radiating, it's not a well circumscribed lesion. It is a radiating type lesion. And it is, yeah, so it is we have a distortion. And what is that distortion? It's moving very quickly. Distortion composed of now. Okay, so you said there are some cystic spaces which are filled with squames. Okay, go ahead. What else are you seeing? Something happening here? Let's go high power. That's the higher power view.
Neoplastic cells
Yeah.
arranged in particular pattern in the stroma.
Yeah.
Ma'am, these cells are round to oval.
Yeah. Before
having-
you go on, can you see one on the low power here or slightly high? This is medium power. All these ductal-like structures. Are you seeing some kind of vacuolated cells as well at the periphery? Kind of. And then there are ductal-like, so almost like recapitulating the normal ducts of the breast, but they're not normal because we don't have the normal lobular architecture of the breast, right? Yes, but there are duct-like structures which have got These vacuolated cells are myoepithelial type cells. And then inside we have the inner ductal epithelial cells, right? So they are recapitulating the ductal structures, but they are not normal ductal structures. Okay, now describe more higher power. So that was the highest power I have. So they are, you said they are round and low grade looking, yeah?
Ma'am, with moderate amount of eosinophilic cytoplasm.
Yeah. Is there
Ma'am,
nuclear pleomorphism? Does it look low grade? Does it look high grade?
ma'am, high grade.
Does it look high grade to you? Yes, okay.
Yes,
Why?
ma'am.
Because unfortunately, I don't have very high power view, but that the nuclei are, when we say talk about pleomorphism, you know the difference between pleomorphism and polymorphism. Polymorphism means there you have different types of cells. Like here, we have myoepithelial type cells and you have epithelial type cells. Pleomorphism, we are talking about, does one nucleus differ from the other nucleus in size and shape? So if one nucleus of this particular duct looks same size and same shape as the other one, then there is not much nuclear pleomorphism. But if it is much, much larger than, if larger than the other nucleus, depending upon, then you call it, yeah, whether it is moderate nuclear pleomorphism or very severe nuclear pleomorphism, right? So we have polymorphism here. In the sense, we have two types of nuclei, two types of cells, but the nuclei themselves, if you look at them, there is not much variation in size and shape. Each nucleus kind of looks like the other nucleus, right? At the most, there is some minimal pleomorphism, you can say, right? So minimal pleomorphism does not go with high grade, right? Minimum pleomorphism means low grade then. And also you take into account the mitotic activity. So there's not much mitotic activity either. So it is looking more like low grade, right? Because there's not much pleomorphism, there's not much mitotic activity. There are some tubular structures lined by two different types of cells. So it appears that it's a low grade type of lesion. Okay, what more is there in this? What am I showing you here? So see, that's the normal duct of the breast, right? But then you have got this, all these islands or the structures going around that. That means it's going around the normal breast tissue. That means it is infiltrating the normal breast tissue, right? In fact, it is infiltrating the fat as well over here, right? So we are happy that it is some kind of invasive carcinoma, right? Now, what type of invasive carcinoma it is? You said some squamous differentiation. You saw some angulated glands or the ductal structures. So any name do you want to give? I have lots of pictures here, but so we have more of squamous, and there are some lymphoid kind of aggregates at the periphery. See these blue aggregates there? Here again, we have some lymphoid aggregates. And if you see here, lymphoid aggregates, and this is normal breast tissue, but that is neoplastic element here. Yeah?
Yes, ma'am.
Again, more of lymphoid aggregates. This is the tumor, while these are the normal ductal structures, normal breast tissue. So it's what I'm trying to show here is that it is infiltrating the normal breast tissue at the periphery. And then what is this? This is the tumor here. And what's at the periphery of that? What is this? Yeah, somebody is saying something. Yes, Sibyl?
Papillons?
It looks like intraductal papillary lesion.
That's right. So it looks like an intraductal papillary lesion. You can't see this very well under high power. I don't have. There is high power. So whether it is, no, that's the highest power I have. So is it benign or malignant? This particular, I think it's difficult for you to say because you can't see very well. But there seem to be both myoepithelial cells, and if you can see the vacuolated cells, which are myoepithelial cells. So it looks like benign intraduct papilloma, right? And there are some entrapped ducts here within the capsule. Typically, the intraduct papilloma is surrounded by a capsule, right? Fibrous capsule. So there is a fibrous capsule here. And then there are some entrapped ductal structures here. Why am I showing it to you here? Because there is a tumor here, and then intraduct papilloma is just next to it. So there is some correlation there, some relationship there. That's why I'm showing you. But anyway, before we go to that, what is the diagnosis now?
Syringometastasis of nipple.
Well done, yes. But okay. But if it is in the nipple area, I would call it syringomatous. But I think it is a different name. That is correct interpretation, but I would call it adenosquamous carcinoma.
Low grade adenosquamous.
Yeah. So it is a low grade adenosquamous carcinoma. Yeah. Agree? So in the skin, it is a skin counterpart of the syringomatous tumor, but it is in breast, we call it low grade adenosquamous carcinoma. Okay. So what is low grade adenosquamous carcinoma or adenosquamous carcinoma? It's a rare form of metaplastic carcinoma.
Metaplastic carcinoma.
Yeah. The aged area is about 20 to 88 years, often has a palpable mass, and it is an irregular mass with ill-defined borders. It's not well circumscribed. Very rarely, very, very rarely it can present as well circumscribed, but most often ill-defined margins. And it's characterized by infiltrative angulated glands or ductal structures with variable amount of differentiation. There are usually lymphoid aggregates at the periphery. Immunoprofile, because there is squamous differentiation, because you have got epithelial and myopithelial cells, you will see P63 positivity both in the myopithelial cells as well as in the epithelial component because there is squamous differentiation, right? So you'll see P63 positivity in both cells. Normally, only myopithelial cells are positive. And typically, they are triple negative. Prognosis, the indolent, they are locally aggressive, so you need to excise it completely. Metastasis is very, very rare. So the complete excision is what is needed for the management point of view. Role of sentinel lymph node and radiotherapy is very debatable because these are very indolent tumors. They can be associated with or they can arise from complex sclerosing lesions like radial scar or intraduct papillomas or nipple adenomas. That's why I was showing you this papillary intraduct papilloma, which was right at the periphery of the lesion. So probably arising from the papilloma, our case arising from intraduct papilloma. So what are the diagnostic challenges for diagnosing these lesions and low-grade adenosquamous carcinomas? Sometimes you get very bland, just spindle cell proliferation. So you may not see the islands of squamous cells or tubular or ductal structures, and they can mimic fibromatosis or fibromatosis like spindle cell carcinoma. Now, I will show you one case here. This is a core biopsy. It was done for, again, ill-defined lesion, mass lesion, but ill-defined. And you can see it is a very infiltrative type lesion. But you see that there's a lot of spindle cell stroma here. Of course, we do have a lot of structures which look like squamous as well as the ductal elements here. But suppose you had only this spindle cell component everywhere. Yeah, it can look like fibromatosis or it could be fibromatosis like spindle cell carcinoma. So when you get anything which has got just bland spindle cell proliferation, I'm not talking about high-grade spindle cell proliferation. Always rule out fibromatosis like or adenosquamous carcinomas. Look hard for these structures. They can be very focally present, or sometimes you may even have to do multiple cytokeratins to find this epithelial component within this lesion. Here we don't have problem because we have squamous component here. So that was one challenge when you have very bland spindle cell proliferation. If it is low grade, do look for epithelial elements. You don't want to miss low grade metaplastic spindle cell carcinoma. The other challenge is the close mimics. Now, any sclerosing lesions, whether it is radial scar or complex sclerosing lesion or sclerosed papilloma, or sometimes even sclerosed fibroadenoma, you can have entrapped and angulated ducts and even squamous metaplasia within the lesion. So I'm going to show you a couple of examples here. This was a core biopsy from R4 stellate type lesion. It was R4, it was suspicious. So if we'll concentrate on this area, so we have that R4 lesion here, kind of stellate type lesion. So if you look at this area, we've got some kind of bland spindle cell proliferation, plus we have this kind of not exactly squamous, but squamoid islands here of cells. But if you look at the different area, now I'm going to concentrate here, and here it looks like a radial scar, right? You have fibroelastotic stroma here, and this is a benign duct here. So you can get within a radial scar, you can have areas which look like adenosquamous. So we call it adenosquamous proliferation within the radial scar. So this was basically a benign adenosquamous proliferation within a radial scar. Another example was an R3 mass lesion. And if you look at this area under higher power, again, we have like squamous type lesions, we have bland spindle cell proliferation. And in fact, on the core biopsy, it was suggested that this could be low-grade endosquamous carcinoma, but this was a well-defined mass lesion. So it was not fitting very well with the clinical or radiological findings. So, but if you, so, let's just move, okay. So this is the area which looked like low-grade adenosquamous proliferation, but within a well-defined mass lesion. We had a well-defined mass lesion here. That's the normal breast tissue there. So, but because there was a possibility of adenosquamous carcinoma was raised by the pathologist, the lesion was excised. And you can see it is a very well circumscribed lesion, very well circumscribed lesion. Maybe probably a sclerosed papilloma because we are getting some papillary proliferation here. If you see under high power, it looks like adenosquamous carcinoma, right? It looks very similar to our case. We have got angulated ducts, some squamoid looking cells, right? Only problem is that it is limited to the lesion. It's not going outside the lesion, right? It's all within the, it's limited within the confines of the lesion. It's within the center of the lesion. And that's what I was trying to show you when I was showing you different images of the case, that it was going in between the normal breast tissue. It was infiltrating the surrounding breast tissue as well as fatty tissue. So that is the way you differentiate. So this was benign adenosquamous proliferation within the, it's moving fast. Yeah, so it is limited. So that is the main thing, that adenosquamous carcinoma will infiltrate the normal breast tissue beyond the lesion. So you really need to see the periphery of the lesion. Is it going into the normal breast tissue? That is how you differentiate benign adenosquamous proliferation, which is a reactive proliferation, which you can get within the lesion, but not outside the lesion. And the last challenge is because it has got very ill-defined peripheral borders, estimation of the size of the lesion, and more importantly, the margin evaluation, because size little bit here and there may not matter, but the margin evaluation, because if the surgeon has done lumpectomy only, you want to know whether it is excised completely or not, because if it is not excised completely, it may come back. And that is where the lymphoid clusters will help you. I was trying to show you the lymphoid aggregates. That's because they are usually at the periphery of the lesion. So if you have nice lymphoid aggregates at the periphery, it's quite likely that is the end of the lesion in there. And if it is well away from the margins would be then negative, considered negative. That's why I was showing you lymphoid aggregates. So the first three cases now together, the theme is triple negative breast cancers, because low-grade adenosquamous is also triple negative. So they could be low-grade or high-grade. So within low-grade, we saw some salivary gland-like carcinomas. Actinic cell carcinoma is low-grade, but it's not salivary gland-like carcinomas. And then you have low-grade metaplastic carcinoma. So I showed you the example of low-grade adenosquamous carcinoma and fibromatosis like spindle cell, which is more or less kind of similar. If you find even some squamous islands within this fibromatosis like carcinoma, it will be low-grade adenosquamous carcinoma. So these are the low-grade cancers. And then you have high-grade, which is conventional metaplastic high-grade, conventional basal-like or metaplastic high-grade triple negative breast carcinoma. So when you give a report, pathology report as triple negative breast carcinoma, make sure that surgeon gets the, you have to mention whether it is low grade or high grade, because the management is completely different. Because if the surgeon suppose misinterprets as high grade triple negative breast cancer, that patient is likely to get neoadjuvant chemotherapy, which is definitely not needed in low grade triple negative breast cancer. So that's the message. Make sure you write in your report and it is very clear to the surgeon that it is a low, and the oncologist, that it is a low grade triple negative breast cancer. You don't want to give chemotherapy to those patients. Okay. So that's the triple negative. Any questions before we go on to case 4? Any comments, questions?
No, ma'am.
No?
No questions.
Okay. Case 4, 47. I don't know whether you get biopsies for calcifications, but I thought I would put one case for calcifications here, because we get a lot of biopsies for calcification because we have a national screening program. So this was radiologically suspicious. So R4 calcifications within the right breast, and these were biopsied. Okay, volunteer.
Ma'am, may I?
Okay, go ahead. Rishabh, okay, go ahead.
So ma'am, here are core biopsies from the breast.
Yeah.
Shows
Done for calcifications, right? Not for mass lesion, right? Go ahead.
shows some lobular structures. Can we go on high power?
That's too high. Okay.
Yes.
Yeah.
So at places, it's showing some back-to-back lobules filled with
Yeah.
monoclonal cells
Mhm.
which are present in solid pattern.
Mhm.
And in between them, there is intralobular stroma.
There's some other people talking in the background.
Dr. Meghna, Dr. Meghna, please mute yourself.
Mute yourself, please. Yeah, go ahead. Go ahead, Rishabh.
Ma'am, there is intralobular stroma present.
Yeah. Yeah. So did you find calcifications? I mean, in this case, it's probably whether you find calcification or you don't find, it doesn't matter. We know, I'll tell you why it doesn't matter, but we do have calcifications here, right? Those are the calcifications there. See that? That they always get fragmented when you try to cut the sections because they are so chunky and they are very hard. So they get fragmented. So we do have calcifications here. So these are the lobules you are talking about, which are expanded by some kind of proliferation with some stroma in between. Yeah, good description so far. Go ahead.
Ma'am, there are some cells, tumor cells, which are vacuolated, having cytoplasmic vacuoles.
Yes.
And few signating cells are also present.
Well done. Very good observation. Yes. Go ahead.
And also there is spilling of some tumor cells in the stroma, which are arranged in back-to-back, that is Indian file pattern.
Yeah. Here. Yes.
So, and ma'am,
Yeah.
there are a few lymphoid aggregates are also there.
Yeah. But these are the ones you're talking about, Indian file pattern. Yeah. That's the highest number. Yeah. Somewhere here, we got a lot of single cells as well as Indian filing. Yes. Over here as well. So what's your diagnosis?
Ma'am, it may be lobular carcinoma.
Yeah. So obviously radiologist had not seen invasive cancer, which is quite often happens when we get biopsies like this, when they've seen only calcifications. So what exactly is happening in the lobules? So what are these calcifications? What do they represent? See, calcifications are not benign or malignant. The calcifications themselves, they look the same, whether they're benign or malignant. It's the associated lesion, which is benign or malignant, right? So what is producing calcification here? Is the lesion which is producing calcification, is that benign or malignant? And what is that lesion? You got your diagnosis right, but I'm just trying to ask you, I want you to know this lesion as well. What is this lesion? Which you probably won't see very often over there because These are usually seen in screen detected cases, usually. So we have these lobules which are expanded by this proliferation. We have these lobules which are expanded, right? And these lobules, whatever is expanding these lobules is also producing the calcification. But we have calcification within those lobules. And I think you can see some necrosis here. So there is some commido necrosis as well. So these cells, do you think, I mean, they're well circumscribed with these nodules, right? So is this, if I forget the invasive component, is this in situ component? Is this, what is this component here? I know you have seen this invasive component here already, which is you said invasive lobular carcinoma, which is correct. But if you didn't have invasive lobular carcinoma, what would you have all this? Because these are well circumscribed nodules. They don't look invasive, right? And I can tell you, if I do myopithelial cells, they'll be present at the periphery. So is it an in situ cancer here?
Yes, ma'am.
Yes. So what type of in situ cancers? What are the different types of in situ cancers? Which are the two main types of in situ cancers? DCIs and LCIs, right? Ductal carcinoma in situ and lobular carcinoma in situ, right? Have you, when you see your invasive, whenever you get invasive cancer on a biopsy or even in excision, do look around and get yourself acquainted to if there is associated DCIs or associated LCI, what it looks like. Don't just ignore that, because sometimes you may end up with a biopsy which will only have in situ component. So you have to know what it looks like. So whenever you are looking at your invasive cancers in mastectomy or lumpectomy or core biopsy, look at the periphery, look at is there any DCIs or LCIs, and pay attention to that. What do they look like? What do the cells look like? What is the difference between LCIs and DCIs? Yeah. So I will tell you this one is actually LCIs. Okay. Why is it LCIs? One is that you described very correctly all these things, that you have signature cells, not that you don't get any LCIs, you can get that, but there are signature cells, but there are also discohesive between the cells. You have some space, right? So they are discohesive cells. They have a lot of cytoplasm, and I will talk about LCIs later. So, and there is no lumen formation, there are no duct formation, but you can get solid DCIs as well. So now your differential diagnosis over here, is it LCIs or is it DCIs? So you try to differentiate it first by morphology, and then if you require, you will do immunohistochemistry. The morphology, I told you that one is that they are discohesive cells. You will get intracytoplasmic lumina in LCI cells, and they will not form duct. There will not be polarization of cells around the duct-like spaces. So those are the differences between LCIs and DCIs. And then I will talk about, this is actually a pleomorphic LCIs, because the cells, the nuclei are 3 times or 4 times the size of the lymphocyte. They have prominent nuclei, and there were mitotic activity somewhere, and there was also commido necrosis. So this was a pleomorphic LCIs with invasive lobular carcinoma. So you can see nice invasive lobular carcinoma. So what I'm trying to say is that when you get pleomorphic LCIs, so here the diagnosis within the lobule is pleomorphic LCIs. When you get that, always look for invasive lobular carcinoma around it, even though radiologist has not seen it, because quite often I find invasive lobular carcinoma. There may be just few cells, 7, 8, 10 cells, but I find them. So don't miss invasive component in pleomorphic LCIs, as well as another variant which I'm going to talk about later. Okay, and whenever you have lymphoid aggregates, do look around, because that is the place where you might find your invasive cancer. And here we got a lot of invasive cancer. But that is the problem with invasive lobular carcinoma. Radiologically, it can be very subtle and it can easily be missed. So this patient actually had very large invasive lobular carcinoma, but it was like multiple foci connected by pleomorphic LCIs. Okay, so the diagnosis is pleomorphic and LCIs with invasive lobular carcinoma. So the differential diagnosis, as I said, is the high grade DCIs, because it's high grade. It is high grade DCIs versus pleomorphic LCIs. So how do we differentiate? I told you the morphological features: discohesiveness, polarization around ductal spaces, intracytoplasmic lumina. So these are the morphological findings. But if you are still stuck, you can do E-cadherin stain. E-cadherin is typically negative in LCIs, but it's positive in DCIs. Whether it's high grade, low grade, it's the same. E-cadherin is negative in LCIs, positive in DCIs. But as with any other immunostains, you have to know the caveats. You need to know sensitivity as well as the specificity of that particular stain, and also how it works in your lab. And over a period of time, it may change your sensitivity, but in your own lab, make sure that you revalidate your antibody at certain interval, like 6 months or 1 year interval. So what are the caveats of E-cadherin? We know that invasive lobular carcinomas are usually, lobular carcinoma cells are usually E-cadherin negative, but about 15% of invasive lobular carcinoma can express E-cadherin, and vice versa. 15% of invasive ductal carcinomas can have loss of E-cadherin. Okay, we don't know the prevalence in LCIs, in situ lobular carcinoma, what percentage of cells are negative to E-cadherin, but they can be negative. And then you have to be aware of this aberrant expression, which if you get aberrant expression, is more likely to be lobular. So just what are you expecting with E-cadherin stain is that complete, very intense membranous staining. That is DCIs. Okay, so what is aberrant expression in lobular carcinoma? I will just show you all the examples. So you can have fragmented membranous positivity. So this is likely to be lobular carcinoma. It is not complete and it is not intense. You can have weak circumferential membranous like this. Again, it's not intense. So that's not DCIs. You can get perinuclear dot-like positivity, or you can get cytoplasmic. If it is DCIs, you will get cytoplasmic as well as mainly membranous positivity for E-cadherin. So you need to be aware of all these caveats of E-cadherin stain. Okay. So in our case, E-cadherin was negative, so it was pleomorphic LCIs. Can anyone tell me what is this? This is part of one other area of our case, but E-cadherin is positive here.
Pagetoid spread.
Well done. Who answered that? Whoever answered it. Yeah, it's a pagetoid spread. So what exactly is the pagetoid spread? What do you mean by pagetoid spread?
Human, we see the cells now. When the tumor cells are proliferating in the duct, in the lumen, we are seeing the spread now, just like in Paget's disease now.
Right. Basically, what happens is that these cells creep in between the myopithelial cells and the ductal epithelial cells. So E-cadherin stain also stains myopithelial cells. Don't forget that, and it stains the normal ductal epithelial cells. So actually, over here you can see there are myopithelial cells here, and these lobular carcinoma cells are creeping between the ductal epithelial cells and myopithelial cells. So you will get positivity towards the lumen because there are normal ductal epithelial cells. You will get positivity towards the periphery because they are the myopithelial cells. But in between, you got the lobular carcinoma cells which are E-cadherin negative. So you have to be aware. So don't consider this as positive and say, okay, that's one lobular carcinoma inside. Okay. So well done, Grishma. This is a pagetoid spread of lobular carcinoma. Okay. And then if your say E-cadherin stain is aberrant, but you are not 100% sure, then you can do beta-catenin or P120. So what do you see with those? E-cadherin's typical immunoprofile of LCIS is, and this applies to even invasive lobular carcinoma, is that they are E-cadherin negative. Beta-catenin, they have lost a nuclear positivity for beta-catenin, and P120, you get cytoplasmic positivity. So this is the typical immunoprofile of lobular carcinoma, whether it is invasive lobular carcinoma or in situ carcinoma. But one thing I must tell you about invasive lobular carcinoma, there is really no need to do immunohistochemistry. Morphologically, it looks like invasive lobular, you call it invasive lobular, because the management for invasive, I'm emphasizing it again and again that this is for invasive breast cancer, because the management is exactly the same, whether it is ductal or lobular. lobular, which is the grade which is more important. And whether the invasive lobular carcinoma is ecardioid negative or positive, it does not matter. So don't routinely start doing ecardioid in all your invasive lobular carcinoma. Unless sometimes preoperatively in the core biopsy, if the breast tissue is very dense, and if you say it is invasive lobular, they would do MRI just to see the extent of the tumor. But that is again, I think that even in invasive duct carcinoma, they should be doing if it is very dense breast to size the lesion. So really the utility of immunohistochemistry to type invasive breast cancer, whether it is lobular or ductal, it is for very limited utility. Okay. So now, because our differential diagnosis was DCIS versus LCIS, why is it important to differentiate the two? So clinical presentation is different of DCIS and LCIS, natural history is different, and management is different. So DCIS is typically a segmental lesion. What I mean by segmental lesion is that it is usually limited to one quadrant of the breast. It can be multifocal in that particular quadrant, say upper outer quadrant or upper outer quadrant segment, but it is usually segmental. It does not unless it's a micropapilla, it may spill over into the other segment. So usually it is segmental, unlike LCIS, which I'm coming in the next slide. It is a precursor lesion. That means if it has to go to develop in invasive cancer, it would be at the site of the DCIS if it has been left untreated or incompletely excised. So the risk is at the site of the lesion. And hence the treatment goal is complete eradication. That means you do either lumpectomy or mastectomy, you completely excise with negative margins. Now, how much negative margins? It is up to your oncologist and surgeon, because people accept different margins in different countries. We need 2 mm margins for in situ, and for invasive we need 1 mm margin. I don't know what the practice over there is. With or without radiation or chemoprevention. Again, practice of radiation is different in different countries. Even in the same country, it is different. Where for DCIs, some people will give radiation for all DCIs, whether it is low grade or high grade or intermediate grade. In some centers in the UK, my center, they will not give it for low grade DCIs once it is completely excised. And chemoprevention is again hormonal therapy, so they will ask you for ER and PR and to prevent recurrences. Okay. So you need to find out what is what your oncologist would want from you. And we routinely don't do ER and PR in DCIs cases because we don't give hormonal therapy after complete excision. LCIs, in contrast, is often multicentric, so it is multi-segmental, and it is quite often bilateral. It is not only a precursor, but it is also risk factor. What do I mean by that? When the precursor lesion means you get, if it is not excised completely, you will get invasive cancer at the site of the lesion, previous lesion. Risk factor means you don't not only get it at the site of the lesion, but even distant from the lesion, away from the lesion. So maybe your LCIs was in the upper outer quadrant, you may get invasive cancer in the lower inner quadrant or even the other breast. And that risk is about 1 to 2% per year. It's more commonly ipsilateral than contralateral, and again, the invasive cancer which develops is more often lobular, but you can get ductal as well with LCIs. If it is classical LCIs, it's a conservative approach, which I'll talk about later. But if they've got variants or different subtypes, you go for excision. So let's talk about that. So classical LCIs, the breast cancer in general, we have low grade pathway and high grade pathway. They're completely different. Low grade pathway is very different from high grade. Low grade recurse usually is low grade, high grade recurse is high grade. So where does classical LCIs fall into? It falls into the low grade pathway. Why? I'm talking about classical LCIs currently, classical lobular carcinoma in situ. It has got the low grade cytomorphology just like low grade DCIs. It's usually ER positive, PR positive, HER2 negative, and it's typically 16q minus 1q plus. Okay. And so the difference is, so how does it differ from DCIs? So DCIs also has all these low grade DCIs, but classical LCIs in addition has inactivation of CDH1, which leads to loss of ecardiorin. Okay, that's why we have ecardiorin negativity in LCIs. So let's talk about classical LCIs. It usually is an incidental finding. So you are not going to see as a targeted lesion which has been biopsied, right? You will see it maybe in a fibroadenoma. Sometimes you may see incidental LCIs, or maybe fibrocystic change and you find incidental classical LCIs. So it's almost always an incidental finding. Okay, it has got low grade cells because it is low grade, and there are two types of cells: type A and type B. Type A means has got very little cytoplasm. Type B has little more cytoplasm. Why I'm saying is that don't confuse type B cells with pleomorphic LCIs, because pleomorphic LCIs is a totally different beast. Okay, so there is no pleomorphism. So it is type B, but there is no pleomorphism. There is no necrosis. Typically, ER positive, HER2 negative, 567 low. They are ecardiorin negative, and they have a lobular signature, which is inactivation of CDH1, which is in ecardiorin negativity. So what do you do when you get classical LCIs in a core biopsy? Again, I don't think you are likely to see that, but we see this in screening program because say a patient has florid sclerosing adenosis, which is producing calcifications, and we get a biopsy for calcification. It is actually sclerosing adenosis, but it is involved by classical LCIs. So what do you do then? Sclerosing adenosis does not require excision. We don't do excision for that. It's a benign lesion. But if there is a classical LCIs along with sclerosing adenosis, what should we do? As long as if it is classical LCIs and not the variants, you still take a conservative approach. So what we ask them to do is that because it can be associated, already may be associated with invasive cancer at the site. So we ask them to provide us with little more tissue, which could be either vacuum assisted biopsy, so we get more tissue, or it could be localization diagnostic lumpectomy. Okay, so they will excise very little tissue. We just want to see whether there is no already invasive cancer in the vicinity. Okay, that is the only. So we still take a conservative approach. We don't try to excise it completely. So they upgrade that may be associated with invasive cancer or DCIs. And if there is nothing after say diagnostic lumpectomy or vacuum assisted biopsy, then the patient is just the woman goes into active surveillance. We have a screening program we call it after 3 years anyway. Routinely we call it every 3 years. But you must excise if the targeted lesion is not present in the biopsy. So you kind of ignore that LCIs and see where is the targeted lesion. Say it was done for an R4 mass and you found the LCIs, but that R4 mass is not present in your biopsy, right? So then you must excise it. Or if it is associated with high risk lesion, we always excise the radial scar. So radial scar with LCIs, we would excise it. But radial scar without LCIs, or just classical LCIs without radial scar, we will not excise it. Radial scar we will excise it, but LCIs without radial scar, without any associated high risk lesions, we will not excise it. Okay, so this was classical LCIs. And same thing if you have a lumpectomy, say it is lumpectomy has been done for invasive lobular carcinoma, you got it, and now you have classical LCIs in the background, right? I'm sure you would get that. So do you try to achieve margins for classical LCIs? Say classical LCIs at the margin, invasive lobular carcinoma is not at the margin. No, there is no need to go back and do more margin excision. Classical LCIs at margin does not require excision. Okay, and you don't even de-excision, and you don't even report it. And also classical LCI, when you give total size of the tumor, you don't add size of classical LCIs with invasive lobular carcinoma, which we do for invasive duct carcinoma. We add DCIs and invasive duct carcinoma to give total size. You all probably are using the proforma, right? ICC proforma, and in there is a column for total size. Total size means invasive cancer with in situ cancer. But for invasive lobular carcinoma, you don't add LCIs. Classical LCI size, you don't add it. Otherwise, it will become a very large tumor. And classical LCIs you ignore at the margin. Okay, so LCI subtypes of the variants are the pleomorphic LCIs and florid LCIs. Okay, they constitute less than 5% of LCIs, but actually in screening program, we are seeing more and more of this. Morphologically, they mimic DCIs. These are relatively new entities. Does that mean that they didn't exist in the past? They did exist in the past, but we used to take them as, we used to report them as DCIs. But now with the E-Career stain, when we started doing E-Career, we realized that all these are basically negative, just like classical LCIs. So these are now recognized as pleomorphic LCIs and florid LCIs. So yes, they did exist in the past, but we were misdiagnosing, but okay, we didn't have E-Career stain at that time, we didn't know about it. We used to call them DCIs. So they have the same lobular signature, loss of E-Career and all this, but in addition, they have some other mutations. So they have other bad features. So where do they fall? Pleomorphic LCIs and florid LCIs. Do they fall in low-grade pathway or high-grade pathway? I don't think we know yet because these are still relatively new entities. Maybe somewhere in between. But yeah. So what is pleomorphic LCIs? Usually we see them, you are not likely to see them very often because they present with mammographic calcifications. Why? Because there is communonecrosis in them and that necrotic material gets calcified. So we get pleomorphic cells with or without necrosis. We may not get necrosis in your biopsy. It is a mimic of high-grade DCIs. Immunohistochemistry, they are negative for E-cadherin, but and they are usually ERPR, very weakly positive or it can be negative. And same way HER2 can be negative or positive, and they have high Pi67 and they have additional mutation. And similarly from pleomorphic LCIs, you have pleomorphic invasive lobular carcinoma, and they have a similar immunoprofile. They can be HER2 positive. So the pleomorphic lobular LCIs and pleomorphic invasive lobular carcinoma, and then the again, when you see any variants, you will also see some classical LCIs in the background. Quite often they just coexist. Okay. The why pleomorphic LCIs you want to recognize because the upgrade rate to invasive carcinoma is 40%, like in our case, and which may not have been seen by the radiologist on the mammogram. Okay, and up to 77% are associated with either invasive carcinoma or DCIs. So whenever you see pleomorphic LCIs on a core biopsy, make sure you look very carefully that you are not missing an invasive lobular carcinoma. You may have very few invasive cancer cells, but look for them. Florid LCIs, again, mammographic calcifications. Cytomorphology, in contrast to pleomorphic LCIs, cytologically cells are identical to classical LCIs. That means they are low grade looking. Okay, so they are either type A or type B cells. They are not pleomorphic, but there is a confluent mass-like architecture. Right, it does not form a clinically. There is no clinical mass. Okay, there is no patient doesn't present as mass. It is under the microscope. You will see that it's so confluent that it looks like a mass lesion. Okay, and each lobule which is involved by this LCI cells, the size of the lobule is around 50 to 50 cells in diameter. Now you're not going to count all the cells starting from here to here. Are there 50 cells or not? Just if it is if it fills up your high power, then it is one lobule which is involved by this proliferation. It fills up your high power of your microscope, high power field of your microscope, then it is likely to be florid LCIs. You may or may not get comedonecrosis. So there is some difference in the past definition from the current definition. In the past, we used to call it there has to be comedonecrosis, but now comedonecrosis is optional. You may or may not have, but if you have markedly expanded lobules or ducts filled with these LCI cells, it is florid LCIs. So it mimics intermediate grade DCIs because it is solid and they are low grade cells, right? So it mimics intermediate grade DCIs. Immunohistochemistry, they are usually ERPR positive because they look like low grade and they are E-cadherin negative and they have additional mutations. Again, same thing as pleomorphic, they often coexist with classical LCIs, 40% upgrade rate and up to 75% associated. In fact, florid LCI is probably even rarer than pleomorphic, and I think whatever cases I have seen, there was always an invasive cancer with it. So do look hard for invasive cancer. So that's your classical LCIs. Florid LCIs looking like classical LCIs, but markedly expanded lobule. And pleomorphic LCIs, they say that the size of the nucleus should be 4 times the size of the lymphocyte. Okay, and they will have a lot of cytoplasm. They are discohesive cells in contrast to DCIs. So how do you manage the subtypes? Now we know that classical LCIs does not require an aggressive approach. It's a conservative approach for classical LCIs. But for subtypes, florid and pleomorphic LCIs, you need a different approach. We know that in the past we used to call them DCIs. So should we continue treating them as DCIs? That may be over treatment. Or should we treat them as classical LCIs? That probably is an under treatment. We are still learning about these entities, how to best manage. Currently, what we are doing in the UK is that we require complete excision with clear margins. So just like DCIs, we need 2 mm margins for florid LCIs as well as for pleomorphic LCIs. After that, whether to give radiotherapy and tamoxifen, we don't know because LCI cells in generally are not radiosensitive. So the role of radiotherapy is uncertain. Of course, if there is associated invasive cancer, this I'm talking about after breast conservative surgery, not after mastectomy. After mastectomy, you're not going to give radiotherapy. But after lumpectomy, if there is an invasive cancer, patient is going to get radiotherapy. But if it is pure pleomorphic LCIs or florid LCIs, after lumpectomy with clear margins, whether to give radiotherapy or not is debatable. We don't know much about it as yet. Okay, so that's all about LCIs. Any questions?
Yes, now we have few comments and questions. First is, what is polarization in DCIs?
Yeah, the polarization means you will have kind of lumen formation and the DCI cells are arranged around that as if they're forming a duct, which you will not get in LCIs unless LCIs which is involved by collagenous spherulosis, it will mimic DCIs, but it's still not a duct in LCIs. So what I'm trying to say, LCIs don't form lumina, the extra outside the cells lumina, they have intracytoplasmic lumina, but they don't polarize themselves around a duct-like or luminal space. That is polarization. Got it? I can show you the one second. Go back to that first picture of DCIs. Yeah. See, this is solid. We are not seeing any polarization of the cells around them. Now, look over here. These cells are polarizing around this ductal space. Look here. I mean, I don't have a high power here, but see, they're forming a ductal-like spaces, right? See here, here. Kind of they're polarizing around some cells. Here, they're just haphazardly arranged, right? So that is polarization. Okay. What's the next question?
Next is, ma'am, I think you already mentioned about P120, whether it's equally useful in LCIs.
I don't do P120. Actually, I don't have that stain. Usually the morphology is quite helpful. If you look around properly, there is cohesive cells and all. I use E-cartilage, and if I stuck, then I will use beta-catenin. It is useful only, I mean, it is important only if it is in situ cancer, right? But at the same time, on a core biopsy, suppose I have an in situ cancer and I'm not able to differentiate whether it is LCIS, pleomorphic LCIS, or whether it is, I'm not talking about classical LCIS, but I'm talking about whether it is high-grade DCIS or it is pleomorphic LCIS. Does it really matter for the immediate management of the patient? No, because both of them require complete excision. And when we get complete excision, we will have a lot more areas to look at, and a lot more if we can always repeat E-cartilage and beta-catenin on that. So yes, you can do beta-catenin. I don't use P120, but sometimes I use beta-catenin. But I feel that immediate management is still the same for high-grade DCIS or pleomorphic LCIS. It's the latter management, because if you're not going to give radiotherapy to pleomorphic LCIS, you are definitely going to give radiotherapy for high-grade DCIS. Yeah, so it does matter after the excision. Okay.
One more question, ma'am. Can LCIS be precursor lesion of invasive ductal carcinoma?
Yes.
Because they are asking many times LCIS is accompanied by invasive ductal carcinoma rather than invasive lobular carcinoma.
Yeah, you can get ductal carcinoma because LCIS is both precursor as well as a risk factor. So it is a non-obligate precursor. So yes, you can get invasive carcinoma. Usually it is lobular, but you can get ductal. Yes. I have seen the LCIS and ductal. You probably would have heard of Rosen's triad, which usually is like LCIS, DCIS, flat epithelial atypia, invasive carcinoma, which could be tubular or it could be lobular. So yes, you can get ductal carcinoma with LCIS.
Thank you, ma'am. I think we are done with the question.
Okay, so if you want to take a break, let me know. Otherwise, we have how many more? Two more cases?
Two more cases.
Yeah.
I think we can continue. Students,
Okay.
I think.
Yeah. Okay. So next case now. Okay. This again, I'm not going to talk about this because I know your next topic is papillary lesions, isn't it? So case 5, 43 years old, radiologically indeterminate cystic solid lesion, R3 right breast. Core biopsy was done, and we had reported it as, I won't tell you the diagnosis, and this is the excision, and we have got 2 blocks for review. So I want you to describe both blocks. Who's describing?
I would like to go for it, ma'am.
Okay, go ahead, Krishna.
Ma'am, this particular block shows that it's probably a lumpectomy or mastectomy specimen because the base isn't green.
Yeah,
And
it's lumpectomy, yeah.
basically the slide shows multiple dilated spaces and surrounded by few hemocytin-laden macrophages, as I can see. On higher power, ma'am. On higher power, I can see these spaces are filled with filiform arborizing cores, which are lined by neoplastic cells.
Yeah. Anything else you describe the hemocytin? What is this structure?
Ma'am, it's capsulated, ma'am.
Yes. So it's got a fibrous capsule of varying thickness. Very important to note that. And then, yeah. So now
Ma'am,
you're describing this.
this capsule along with the inside, ma'am, pores are devoid of myoepithelial cell layer, and the individual neoplastic cells, ma'am, they have a moderate amount of eosinophilic cytoplasm. Ma'am, can I go on a higher resolution, ma'am? There is one more.
There's one more? No, that's
Yes,
it.
yes.
Yeah.
So, ma'am, these cells have a moderate amount of eosinophilic cytoplasm, and the nuclei are round to oval with vesicular chromatin pattern and prominent nucleoli, ma'am.
Yeah.
And in the next focus, ma'am, we can see similar tumor cells are permeating into the surrounding stroma.
Yeah, here.
Yes,
ma'am. For you.
Yes, ma'am. And
So-
ma'am, yes, ma'am.
So what is this now? So tell me what is the diagnosis on the rounded lesion, and then tell me what is this lesion. Okay, so let's go back to that one and tell me what is this lesion first.
Just from the first slide, I would like to give it as encapsulated papillary carcinoma. But when I go, ma'am, for the further slide, there is one more slide where the papillary foci is very
we are going to stick to block 1 first. Yeah, and then we'll go to block 2. So in block 1, your diagnosis is
encapsulated papillary carcinoma, ma'am.
what grade?
Ma'am, it looks like a high grade only, ma'am.
Do you think it is high grade? Again, the nuclei are very similar to each other. They are low grade.
Low grade,
Prominent
ma'am.
nucleolus does not make it high grade because you will get some prominent nucleolus in it. So it is low to intermediate grade, I would say. It's definitely not high grade. So it's low to, there's not much nuclear pleomorphism here. So encapsulated papillary carcinoma. If I was to ask you, what B5 category will you put ABC on that lesion itself first before we move on to anything else?
I didn't get your question, ma'am. Sorry, ma'am.
Okay, so you will call it encapsulated papillary carcinoma, low to intermediate grade. What would you tell your surgeon? What is the further management? What would your surgeon interpret it as?
Ma'am,
C, ma'am.
Sorry?
B5.
Sorry?
ma'am. C.
C. Okay, C is fair enough. Okay, so when we come to the discussion of that, we will decide what are the problems with this. Anyway, so encapsulated papillary carcinoma. Okay, in over here, if I have to give, I would have said B5A here without looking at other areas. Okay, I'm just talking about just this because we don't have any conventional invasion. I'm not worried about anything here. So this would have been B5A or in situ carcinoma, managed as in situ carcinoma, right? Because finally you have to give T stage, right? TNM T stage. So if I was to give a T stage only on this, if we ignore the block 2, it would have been PTIS, right? Okay, we are going to talk about it. Now let's go to this area. What do you think?
Ma'am, here the cells are also forming some tubules, ma'am, and small nests, ma'am.
Yeah. So what is it?
Similar nuclear features, ma'am.
Yeah. Well done. So they are very similar to what was there in the lumen of that cystic space. So what is this?
Ma'am, I could suggest that it might be an invasive focus, ma'am.
Okay. What is all this here?
Ma'am, hemocytin-laden macrophages, ma'am.
And what is all this here? What is all this?
Hemocytin-laden macrophages.
This area here.
Necroplastic stroma.
Okay. Yeah, it's a fibroblastic stroma, right? Why have we got hemocytin in kind of almost a linear area over there? Why do we have that?
Probably previously FNSA was performed in that
Well
area.
done. Okay, we don't do FNAs here, we just do core biopsy straight away. So this is a core biopsy tract. Okay, so this is the scar tissue of the core biopsy. And these are the entrapped structures which got misplaced from while doing core biopsy. They got entrapped into the biopsy tract. So this is not a genuine invasive cancer, not on this block. If the genuine invasion has to be outside the fibrous capsule. It's not, if it is limited within the capsule, you don't call it invasive cancer. It has to be outside the capsule. And even when it is outside the capsule, make sure that it is not in the biopsy tract. Because when the needle is pulled out, a lot of tissue, these papillary fragments are very friable. And so they dislodge very easily. And then they get trapped within the biopsy tract. So this is actually a biopsy tract. So this is not true invasion. This is pseudo invasion. Okay, so on this, I would not call this invasive cancer. So and then you saw a lot of DCIs outside around it and all, which typically is associated. So on this slide alone, I would stage it as PTIS. Encapsulated low to intermediate grade encapsulated papillary carcinoma, PTIS. And then we will talk about the terminology a little later. Okay, so this is on block 1. And whenever you get encapsulated papillary carcinoma like this, always block thoroughly, particularly the periphery of it. Okay, so now describe block 2. It's the same case. Huh? So
Yes,
And it's the same lesion. So we still have this encapsulated papillary carcinoma, different area of the same thing. You can see that the capsule, again, it's not always thick capsule all around. It's of varying thickness. Somewhere you will have thin capsule, somewhere you will have thick capsule. Okay. And sometimes you may not even see it in that particular plane, but it is usually surrounded by fibrous capsule. So that we have. Now what do we have here?
Now in block 5, we can again see the same tumor-like foci outside the capsule along with few fibrocystic changes, ma'am.
Yeah. So what is this now?
And these
Is
are
this-
proper.
So is this invasive cancer or it's not invasive cancer?
Ma'am, it is outside the capsule, ma'am. So it is invasive, ma'am.
It is invasive. One, it is outside the capsule. It is nowhere in the biopsy tract, right? So two things you have to take care of. One is that it is outside the fibrous capsule, and second, it is not in the biopsy tract. Okay.
And one
So
more
we-
point I would like to add, ma'am.
Yes,
Ma'am,
yeah.
it is also surrounded by, ma'am, that desmoplastic stroma, ma'am, which
That's
is
right.
holding the tumor around. So I would like to say that this is another part, ma'am, invasion part.
Yeah, so there is one invasive cancer here. Yeah, that we saw. Then there is another one here. But don't forget, there is a lot of DCIs around, right? There's not just fibrocystic change. There's some DCIs here. See, all this is DCIs. This is clearly from DCIs. This is almost papillary DCIs. So this is low-grade clearly from DCIs here. But then this focus is also, and even the first focus here was associated with, we are not seeing, but there was DCIs somewhere down there. So there is DCIs and invasive cancer there. And then there is DCIs, and there is somewhere here we have invasive cancer, right? There is invasive cancer here, right? Okay, that's invasive cancer. So we have invasive duct cancer. We have two foci of invasive duct cancer. Now, how would you stage this? If you were to ask, because do you give normally TNM stage at the end of the report in lumpectomy or mastectomy?
Yes, ma'am.
Yeah. So what T stage will you give here now?
Depends on the size of the lesion also, ma'am.
Yes, that's right. So how are you going to measure? Okay, we'll talk about it. How are you going to measure the size? Okay, let's.
Ma'am, we can correlate with radiology.
We have
and
one focus here and one focus here, right? One here and one here. So how will you measure the size? First of all, what size? What would you measure here? Tell me. Why is it
Ma'am,
doing
the
this?
invasive focus, ma'am. The tumor has the invasive focus, ma'am.
One second. Why is it doing this? Okay, so you are going to. It is 1 second. Okay. Okay. So you are going to measure these two foci of invasive cancer. You're not going to measure the in situ cancer, right?
Yes, yes.
So will you add up the two, or you will measure them separately?
Mm.
Will you add up this invasive cancer with this invasive cancer? So then it becomes bigger than either this or this. So it may be PT1A or it may become PT1C.
Actually, both of them are supposed to be measured separately, and the grade is to be given on the larger size, ma'am.
That's right. No, the grade you will give the worst grade.
Like, tumor size is supposed to be given on
Yeah.
the larger tumor.
Perfect. Perfect. So you give the largest focus always, or you will do something more to figure out what is the definition of multifocal breast cancer versus unifocal breast cancer. This matters for the oncologist. Are these two separate small foci of cancer, or are they one focus but which are slightly separated?
Ma'am, the distance is supposed to be there, ma'am.
Yes. What is the distance?
5 mm distance, ma'am.
Yeah. Okay. Somebody's there. Okay, good. So you have, again, this is very arbitrary cutoff. I don't know how they were come up with 5 mm, but it is a 5 mm cutoff. If there is they are separated by at least 5 mm of benign tissue in between, then you call it multifocal invasive cancer, and then you measure the largest focus and you give the grade of the worst tumor grade. Okay. But before I would call this multifocal, I would do deeper levels. It's quite likely that they will join up in this, and that's what happened in this case. They will join up. So it became a unifocal cancer. Okay, but it was still PT1B, I think, in this case. Okay, so that's very good. So we have got now the final diagnosis here is low-grade encapsulated papillary carcinoma with destructive invasion. Why am I saying destructive invasion? We will talk about it. So if it was a core biopsy, we don't give B category on the excision, so it should not be on this, but only on core biopsy. So if there was already, and again, in a core biopsy, if you see encapsulated papillary carcinoma, always look outside the capsule, even in your core biopsy. Is there an invasive carcinoma with it? And not only that, sometimes there is a lot of DCIs also with it, and like in this case. So when they're looking for the margins, the surgeon will be looking for the margins for DCIs as well. So you have to give separately margin for DCIs as well as for invasive cancer. Okay. So this was low-grade encapsulated papillary carcinoma with destructive conventional invasion. Okay. And so why are we specifically saying that? Okay, I'm not going to go into details of all this because I know your next talk is on papillary breast lesions, but I'm just going to talk about a little bit about encapsulated papillary carcinoma, which are usually central and solitary. They form a discrete mass, postmenopausal women, and they usually get malignant epithelial proliferation within a cystically dilated duct. And as I said, fibrous capsule of varying thickness, and there is often DCIs at the periphery as well, like in our case. Both the cells, because they are neoplastic or malignant, they are malignant, there is CK566 negative. ER will be overexpressed, just like any other low-grade DCIs. Only difference between other low-grade DCIs that in this, when the papers, which was published by Stoisnick a few years ago now, they study a whole lot of this. In the past, we used to call them intrastic papillary DCIs. When they studied all this, they couldn't find myoepithelial cells at the periphery at all. So then, that's why there are myoepithelial cells which are absent at the periphery as well as within the lesion, right? So in the past, we used to call this intracystic papillary DCIs, but now we changed the name to encapsulated papillary carcinoma. Why did we change the name? Because several studies now have shown there's no myoepithelial cells at the periphery of the lesion. And in breast, absence of myoepithelial cells is a surrogate marker for invasive carcinoma, right? There are exceptions like microglandular adenosis, apocrine cysts may not have myoepithelial cells. But in general, absence of myoepithelial cells equates to invasive carcinoma, just like in prostate cancer, absence of basal cells is invasive prostate carcinoma, right? So that's why this encapsulated papillary carcinoma probably represents an expansile type of invasive carcinoma, not the destructive type. Again, we see that in a lot of other organs, right? In ovaries, in skin also we see, which like very nicely well circumscribed nodule, but sitting deep in the fat in the skin, or in the ovary, borderline tumors versus carcinoma, we can get expansile type carcinomas, but they have very good prognosis, right? So this is why name was changed, because there were no myoepithelial cells at the periphery of the lesion. So that's why the name was changed, and it's now considered to be an expansile type of invasive carcinoma. But the clinical behavior is very, very good. Lymph node metastasis is very rare. Only in about 2% of cases you get lymph node metastasis. So should we be treating 98% of cases as invasive cancer? No. And that's why we still stage them as PTIAs if there is no conventional invasion. So the traditional was intracystic papillary DCIs, now it is encapsulated papillary carcinoma. But the behavior is very good and very good prognosis, and that's why it is managed as in situ carcinoma. But there are exceptions, right? But I will come to exceptions. So they are adequately treated by local therapy alone. Again, whether to give radiotherapy or not, that's up to the oncologist, because there is a variation in practice. But you should treat them as invasive cancer. Now we are talking about this encapsulated papillary carcinoma without any destructive invasion. You treat them as invasive cancer if there is high-grade morphology. And that's why it is very important to differentiate whether it is high-grade or low-grade, or triple negative or HER2 positive. Or this is again rare. If you have invasive micropapillary carcinoma within the lesion, you treat it as encapsulated invasive cancer. Then we will not call it B5A on core biopsy. We would call it B5B1 on core biopsy. And this is because when Dr. Rakha and all his colleagues did that study, there were some actually triple negative basal-like carcinomas with EPC-like growth pattern, which were called encapsulated papillary carcinoma and were undertreated. So you don't want to miss those triple negative high-grade basal-like carcinomas, which can look like papillary encysted papillary carcinoma. So that is why they should be treated as invasive cancer. That was their argument, that we should be treating all these. You don't really want to miss those high-grade basal-like triple negative cancers, because once you miss the boat, you miss, because then the prognosis becomes very bad. So you want to really treat them with either upfront chemotherapy, neoadjuvant, or adjuvant chemotherapy. So just to summarize, encapsulated papillary carcinoma, traditionally regarded as in situ carcinoma, with those exceptions, considered to be an expansile type invasive carcinoma because there are no myoepithelial cells at the periphery. Very rarely you get lymph node metastasis, staged as PTIS after lumpectomy if there is no conventional invasion, managed as TCIs, and avoid overdiagnosis. Don't call it invasive papillary carcinoma. Call it encapsulated papillary carcinoma. Right? Any questions on this? So this is, okay, sorry, there's some more. So this is another example with conventional invasion. It's outside the fibrous capsule, it's not in the biopsy tract, and it's invading the fatty tissue all around. So that's treatment. And how do you measure the size? You measure the largest dimension of the invasive component only, don't include the size of the papillary lesion. So in our case, yeah, you measure either this way or this way, whichever is bigger, not if this way if it is more than 5 millimeter, but please do deeper levels to make sure there is no invasive component in between. What are the pitfalls of conventional invasion? I told you that misplaced fragments due to the previous biopsy tract. So biopsy site reaction around the tumor fragments. You have to have the conventional invasion away from biopsy site as well as outside the fibrous capsule. Suppose you are in doubt whether it is really invasive or they are just the misplaced fragments or true invasion. Will immunochemistry help you? No, because these misplaced fragments have come from inside. So there are not going to be any myoepithelial cells even here. So immunochemistry is not going to help you. You have to decide on H&E whether is it outside the fibrous capsule and whether it is not in the biopsy tract, which is in contrast to your benign intrapapillomas. When you get like this and you wonder, is this invasive cancer? You can do P63 myoepithelial markers, because if these fragments have got misplaced here, they will still have the myoepithelial because this is benign. And this is not in invasive carcinoma because there are still myoepithelial cells. So in benign intrapapilloma it will help you, but if it is malignant proliferation, immunohistochemistry is not going to help you. You will have to come down to morphology again on H&E. Okay, so that is it about the EPC. Any questions on EPC?
One question is there. They ask how to differentiate malignant tumors with expansile pattern of invasion from benign tumors in organs other than breast.
Oh, so which organ are we talking about? That's what I'm saying. So suppose in skin or in ovary. So in skin, if you have a very well circumscribed squamoproliferative lesion which looks like squamous carcinoma sitting deep in the subcutaneous tissue, it is invasive cancer, right? But it is expansile type, and it will have a very good prognosis. Most expansile tumors have very good prognosis in invasive cancer. They are invasive cancers, but they have got very good prognosis because there is no destructive invasion. Say in ovary, like mucinous carcinomas, our oncologists will always ask us, is it expansile type of invasion or is it destructive type of invasion? So in ovary, I would call it expansile type invasion when the architecture becomes very, very complex, like back-to-back glands, just like in endometrium, atypical hyperplasia versus endometrial carcinoma. The architecture becomes very complex, back-to-back. I would call it expansile type mucinous carcinoma. And there, if it is still 1A in the ovary, they will treat it as just like borderline tumor because they are not going to give chemo for 1A, expansile type invasion. But if it is destructive type invasion, they will definitely consider chemotherapy. So they would always want to know, is it expansile type or not expansile or destructive type? And same thing applies in the breast and ovary. I don't know much about skin because I don't use kids, but yeah. So that's my answer. Does that clarify you? So I think it depends in the organ, which organ, because you don't expect normal lesion, benign lesion to go deep into the fat unless it is a plane of sectioning, which is called tangential. Yeah.
Yeah. No
Okay,
further question.
Okay, so last one now, 48 years of 3. Pay attention to the history. 3 ovoid, well-defined lesions left, breast, query, fibroid adenomas, R3. Who is describing it? Any volunteers?
Dr. Kayal,
Yes, ma'am.
would you like to describe?
Yeah, yes.
Okay, so this is we have the core biopsies here from well-defined ovoid lesion. One of them is there. So, okay, so we have a well-defined lesion. Start with that.
Here we see infiltrative, ma'am.
Sorry?
Infiltrative neoplasm.
Yeah, but it's okay. The first step, radiologically well-defined lesion. Do we have it in the biopsy? Do we have a well-defined lesion?
Yes, ma'am. We see the normal breast.
Because you can see the interface.
Yes, ma'am.
If you have interface here, we have fatty breast tissue, and then you can see that it is quite well demarcated. It's not infiltrating here, right? It is infiltrated lesion here, but it's not. It has got a very well-defined edge. Let's put it that way. It's a very well-defined periphery. Okay, go ahead next. So infiltrating lesion within okay, we are saying infiltrating islands or tubules or whatever. Yeah.
Composed of tumor epithelial cells arranged predominantly in solid sheath, nest, and tubules, ma'am.
Yeah.
The individual cells are small to medium size, having scant to moderate amount of cytoplasm with ill-defined cell borders, ma'am.
Yeah.
Nuclei show fine stipulated chromatin, that is classical salt and pepper chromatin, ma'am.
Okay.
Some of the tumor nuclei are hyperchromatic due to crushing artifact.
Yeah.
Few atypical mitotic figures are seen, ma'am.
Yeah.
I would like to go with these like ductal carcinoma with neuroendocrine differentiation or neuroendocrine carcinoma of left breast.
Well done. Very good. Very good. Right, now let's come back to our step 1, or rather step 3, interpretation. I must say, when I saw it first, I thought, yes, invasive duct carcinoma, low grade, yeah. But then the third step, does my interpretation match with the clinical or radiological findings? Radiologically, there are 3 well-defined nodules. 3 I can understand. You can get multifocal invasive duct carcinoma. That's not a problem. Well-defined nodules. Now, how often invasive duct carcinoma, low grade, is well-defined? With a sharp kind, almost like a nodule. They've described it as a nodule, kind of. It's very rare. And I will never say never and never say always because anything is possible. But it's very rare. It always infiltrates the surrounding tissue, the surrounding normal breast tissue. There, it kind of just struck that. Why is it so well-defined? Why is it got circumscribed borders, right? So your question that if it was an invasive duct carcinoma with neuroendocrine differentiation, I would have still expected it to be infiltrative type of lesion, unless it is a solid papillary TCIs, right? But this architecture does not fit with solid papillary DCIs. That is a different, I suppose in your next talk it will be covered, so I don't want to go into details of that. But the solid papillary DCIs is actually a neuroendocrine type of tumor. All the cells will be positive for neuroendocrine markers. But your observation was very good. So it's either an invasive duct carcinoma neuroendocrine differentiation, which I would say probably less likely, or neuroendocrine tumor. So now tell me more about it. Now, what will you do next?
I'll go with IHC, like synaptophysin, chromogram, TTF1.
Okay, I would say they are positive. Neuroendocrine markers are positive. Now, how will you report it? And what would you do rather next? Don't forget that I'm not happy with my third step yet, okay? Because it is not mucoid carcinoma and it is not solid papillary DCIs. Those are the two which show neuroendocrine differentiation, and it could be very well demarcated, right? Very well defined nodules. So third step, I'm still not happy with that interpretation. My interpretation is invasive duct carcinoma with very well circumscribed nodule. Not happy with it. So yeah, but at the same time, it is showing me all neuroendocrine marker positivity. So what would you think now next?
We ask the clinician if there is any lesion anywhere else in the body.
Very well done.
Because
Good,
carcinoma
good
from breast
question.
are less than 1%.
Yeah. Pick up a phone and ask, okay, that's what I did. And my surgeon and my clinician said, no, nothing. They don't know because nothing was done. She came with the breast lesion. This was the first presentation. And they had nothing was done, obviously, because it was only presented with breast. So there was nothing. Clinically, there was nothing else. So now what is the next step? You are in the right path. Now go ahead. What can I do on this now?
IHC to
Yeah.
note if it's from breast or not. So we can do GCD, FP, 15, and along with that, ma'am, one more desirable criteria in WHO, it's written that DCI should be there if it's rising from the breast.
Yes, but problem is in core biopsy, it may not be there.
You might not get it. So, ma'am, IHC like
What am I showing you here? ER,
Yeah.
completely negative.
so it is
Now,
not
if
from
it is
breast.
a low-grade invasive duct carcinoma, you want ER positive, right? It would be positive. Very, 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 very rarely low-grade invasive duct carcinomas would be ER completely negative, right? So this would kind of, okay, this could be a metastatic tumor in the breast then. Okay, what is the next step then? ER also okay. Sometimes low-grade invasive duct can be ER negative, maybe, rarely possible. CK7, breast tumor should be CK7 positive. GATA3, negative, right? Okay, so now we know there is not breast primary. Then I suggested, can you look somewhere else? And then they found multiple carcinoma tumors in the small intestine. Okay, and then the patient had liver mets as well, which is doing well because it is a low-grade neuroendocrine tumor. Chi67 index was very, very low. So that is what I'm trying to say is that always consider your 3 steps which I talked about. That has to fit. Even if you have slightest doubt, try to rule out something different. I mean, obviously, it is quite rare to have metastasis as the first presentation, but that's what it was in this case. So the surgeon said there's nothing else. So something doesn't fit. Think of what else could it be. Okay, because you noted it perfectly well that it was neuroendocrine differentiation, even an HNE, which I was very impressed by. So okay. So this was metastatic carcinoid low-grade neuroendocrine tumor. Now you all probably know that the neuroendocrine tumor, now WHO has kind of joined up all organs into one kind of WHO book as neuroendocrine tumors, and it applies to all organs, right? In the breast, it is very, very controversial currently. So what are neuroendocrine breast tumors? There are variable definitions. Different people use different criteria to call something neuroendocrine, and you can see that from here. The incidence anywhere from 0.1 to 20%. 20% is very high. Okay, and normally there are no neuroendocrine cells in the breast. So where are they coming from? These tumors then? So most neuroendocrine neoplasm in the breast probably represent neuroendocrine differentiation in breast cancer or metastasis to breast, right? So this is the neuroendocrine tumor classification of breast. So true neuroendocrine neoplasms, so neuroendocrine tumor, which could be either grade 1, 2, or 3, small cell neuroendocrine carcinoma, and large cell neuroendocrine carcinoma. Large cell neuroendocrine carcinoma, I think that entity, there's so much interobserver variation. I feel that it is, different people call different things as large cell neuroendocrine carcinoma. Invasive breast carcinoma with neuroendocrine differentiation. So basically you diagnose it on morphological subtype. So as I said, the solid papillary DCIs can show neuroendocrine differentiation. You don't call it neuroendocrine tumor. You call it solid papillary DCIs. Similarly, mucinous carcinoma, yeah, it shows neuroendocrine differentiation. You don't call it neuroendocrine tumor. You call it mucinous carcinoma. And similarly, no specific type can show neuroendocrine differentiation. Okay. So if you guys want to read this head-to-head discussion, it's a good one to read, and this table is also very good. So any invasive breast carcinoma with neuroendocrine morphology on HNE. Okay, this is there in histopathology. So as I said, mucinous carcinoma and solid papillary carcinomas, they are typically neuroendocrine. So you diagnose them as such, or invasive breast carcinoma with some neuroendocrine marker positivity. So you diagnose them as either mucinous carcinoma, solid papillary DS, or NST with neuroendocrine. So and then you have got a marker, some focal and weak positivity for neuroendocrine markers. So these are neuroendocrine differentiation confirmed by IHC. So if it is patchy and focal, you just call it NST with neuroendocrine differentiation. But if it is strong and diffuse, you call it invasive breast carcinoma with a neuroendocrine pattern. You still don't call it neuroendocrine carcinoma or neuroendocrine tumor. The only thing you can confidently call it neuroendocrine in the breast is small cell carcinoma, right? So, and then you obviously small cell carcinoma also you need to decide whether it's coming from somewhere else. And again, markers are not going to help you. TTF1 may be positive, doesn't matter. Doesn't mean that it's coming from lung. Okay, so radiologically, clinically, they have to decide whether it is primary small cell carcinoma breast or coming from somewhere else. So real neuroendocrine tumor in the breast is probably just the small cell carcinoma. All others are considered to be variants of invasive carcinoma. So that's what I said. The exception may be small cell carcinoma. So when you get neuroendocrine differentiation or pattern in any other type of breast cancer, invasive duct carcinoma or papillary, it has no clinical significance because they are treated like just NST invasive carcinomas. So neuroendocrine differentiation currently doesn't mean much, but you can read about the debate in a histopathology journal.
Excuse me, ma'am, I have one doubt, ma'am.
Yes.
Ma'am, that NET component, if it is more than 90%, also still we'll call it as neuroendocrine tumor, right, ma'am?
NET components more than 90%. See, that's what I'm saying. Even if it is 100%, but if it is invasive duct carcinoma, suppose this was not a carcinoma tumor, that typical neuroendocrine tumor metastasis, but it was invasive duct carcinoma, NST type. But even with 100% differentiation, you would call it invasive duct carcinoma with neuroendocrine pattern. Okay, and it is treated like NST then. You must read that histopathology article because they discuss all these pros and cons, and there is a lot of controversy currently. So we don't know whether what we are doing currently, treating them as just NST is right or wrong. We don't know when there is 100% differentiation in neuroendocrine. So it's the same thing in other organs also. We see that in colonic cancers as well, like neuroendocrine differentiation, but they're treated as an adenocarcinomas. So it's the same thing in the breast. So yeah, there is a lot of controversy currently regarding neuroendocrine tumors in the breast. But the small cell carcinoma you can confidently diagnose. Everything else is a problem. So when you consider anything which is metastatic to the breast, it's unusual histology. When there is radiological pathological discordance, like in our case, it is looking low grade, but ER is completely negative, or there is a clinical history of previous cancer at other site. And how do you solve? Obviously, first you try to get clinical history, which you say correctly, and then do the markers, breast markers and markers for tumors from other sites. And I think that might be my answer. Yeah. Thank you. So any questions or any comments from chairpersons, please? Any suggestions, anything?
Yeah, I think
Surgeon Gurpreet, you have any comments?
Thank you very much for the lovely talk, Dr. Varsha. And there was a lot of learning for me also. And there are a few points that I would want to make. I hope you can hear me.
Of course I can.
So one of them was that you said in and this is for the interest of students also, that ILC and IDC, while making a diagnosis, don't worry, and you can call an ILC without any cadre in. But for me, it really makes a difference whether the patient is an ILC and IDC to begin with itself, because I would want to know if it is ILC because I can prognosticate accordingly. Also, I would, if it is an ILC and it's a single focus, I would want to ask for an MRI to be sure that I'm not missing out on any, because ILC is known for multicentricity and multiplicity. So hence it becomes important for me to know that. The other thing is that yes, there are differences in practices, like you pointed out, between UK and here. But and that for that reason, for DCIs, we do a lot of ERPR marking because we give chemo prevention after excision. And I think that's followed in some part of UK and some parts don't follow it, because I've seen patients from both these parts and who've come, and one of them is on tamoxifen, the other one's not receiving it because they don't get it.
Yeah.
And the excellent thing that I saw was the hemocytin-laden cells in the core biopsy tract, because it's surprising, because we believe because we're using a coaxial needle, there is not going to be any seeding of the cells in the biopsy tract. So it was very surprising for me, and it was a learning point for me that these things need to be taken care of.
Yeah, it's more common with papillary lesions because they're so friable. It's so friable. So we more commonly see with the papillary tumors. Regarding your ILC and IDC, I agree. Particularly even here, when the breast tissue is very dense, then our surgeons would ask us that is it really lobular or ductal, because they would do MRI. But if it is morphologically typical lobular, I will not definitely do ECADRIN.
It completely depends on the pathologist. If they call it ILC without ECADRIN, I'm happy accepting it as that.
Yeah, but the problem is that we know that, and I have seen that invasive duct carcinomas can be ECADRIN positive. So is it just because? So are you classifying them as ECADRIN positive and ECADRIN negative carcinomas rather than lobular versus ductal carcinoma? So what is your gold standard here? So are you going to treat ECADRIN negative carcinomas something like lobular carcinomas, or not? Because invasive duct carcinomas can be also ECADRIN negative sometimes, 15% of them. So that is the problem. But I feel that in MRI, I agree that they want to look at whether there are other foci or not. But if you are doing lumpectomy, and this argument we have had multiple times even in our multidisciplinary meetings, that should I be doing ECADRIN in all cases if it's going to matter so much? And the oncologist and the surgeon said, well, in the past, when they didn't do MRI, radiotherapy takes care of the small foci of invasive lobular carcinoma after lumpectomy. And if it's a large focus, they're going to see it. Unless the breast tissue is so dense, then they will do MRI even for invasive duct carcinoma to size it. So that's what I wonder. So in a core biopsy, whether it is sometimes yes, if the breast tissue is very dense, then they will second, they will do MRI, but that they will do probably even for ductal carcinoma then. And whether minute foci, whether radiotherapy probably takes care of those minute foci of invasive lobular carcinoma. Otherwise, a lot of people my patient end up with mastectomy then. So we don't know. Yeah, I agree.
I agree with you, because what happens a lot of times is when we're doing MRIs for these ILCs, we don't see tumors, we don't see foci as separate this thing. But what we see on MRI is non-mass enhancements, which then it becomes difficult for you to whether you want to rebiopsy the non-biomass enhancement to see whether there is true multiplicality or multicentricity, and then decide on mastectomy. And yes, a lot of them end up with a mastectomy, and some of them it's completely unnecessary. Yeah. Because don't forget, MRI also has false positivity because a lot of that enhancement, when the biopsy doesn't turn out to be anything. So, that's another debate for another 3 hours, I guess.
Yeah, and I don't know what was your second point. I forgot. Yeah, papillary lesion and something else was there anyway.
The second point was that we do IHC for DCIS as in ERPR for DCIS because we offer chemo
That's
prevention.
right. Even in the UK, the practice is so different. In Nottingham, they will not give hormonal treatment, but they will give radiotherapy to all grades of DCIs. We don't give hormonal treatment or radiation after low-grade DCIs. Only if the patient is not fit for surgery, they will try to give hormonal. In US, again, they will give hormonal treatment even for ALH and even for ADH. So practice is different. Yeah.
So those were the 2 points, and the third was the biopsy tract that I saw the cell there.
Yeah.
Thank you very much for an excellent presentation. It was a pleasure being here.
Thank you. Nice meeting you.
Good evening, Varsha ma'am.
Yes.
It was a wonderful and elaborate presentation, and I'm really impressed. You mentioned the triple negative low-grade breast cancers, because triple negative always warns the clinician about a high-grade lesion.
That's right.
But here, wonderfully described, and students should keep in mind in future that there may be negative carcinoma, which may be of low-grade type. Thank you, ma'am.
Yeah, thanks, dear.
Thank you, Dr. Kia. Dr. Poonam, any comments? I think Dr. Poonam is not there. Thank you very much. It was like really a learning session, very rare and very interesting cases. We all enjoyed it. I think Dr. Kuratil also agree with that. So thank you, really. Thank you. Thank you, Chairperson.